upon, and it's not moving. Okay. Can I start once? Okay. So IOL subluxations can be of varying degrees. Minor degrees of subluxations are noticed. Moderate to severe will be presenting with gross reduced diminished vision, diplopia, raised IOP, and inflammation. So the symptomatic subluxations are to be managed surgically. Either you have to fix it to the sclera, or you can exchange it with iris glow. SFIOL is the most preferred. It can be either sutured or without sutures. So the objective of the study, this is a retrospective study. Here we studied the demographics, etiology, the assess the management methods, clinical outcomes in terms of visual improvement, and the safety and efficacy of the surgical techniques also was studied. The materials and methods, the 11 eyes of 11 patients who were symptomatic and who presented from the duration of July 2022 to 23 were included. And here 11 patients were there. For 4 of them, in situ fixation was done, and for 7 of them, IOL exchange with anterior vitrectomy and SFIOL was placed. So data collection included the logMAR BCVA. Initially, it was measured in Snellens and converted logMAR. Duration since primary surgery, lens status of the other eye, then the ocular predisposing factors, preoperative biometry, OCT, and endothelial cell count, the surgical techniques, and postoperative refraction at 6 weeks, and the complications. An in situ fixation method, either if there is a closed loop, it is done in case of a closed loop foldable IOL, or if there is a C loop with fibrous capsule. Here, 2 scleral flaps are made 180-degree apart, and AC maintenance is used. And using an ionoprolene, which is double arm, one end is threaded, it is introduced from the scleral flap, and from the other end, 26 gauge needle, which docks in the ionoprolene is taken out through the closed loop of the haptic, and it is exteriorized from one of the scleral pockets, and it is tied. The suture goes under the scleral flap and it's not exposed. Next slide. So here, this is a picture just to show that the first needle goes above the IOL, and the second one is passed through the fibrous capsule or within the closed loop of the haptic. Okay. So it goes into the Hoffman pocket, and it is used to bury the exteriorized knot so as to prevent the suture erosion. Now coming to the IOL explantation group, here as in SICS, superior frown incision is made and the anterior chamber maintenance is used to avoid using OBD. The subluxated IOL is dialed into the anterior chamber using Sinskey hook. Explanted using McPherson forceps, the anterior vitrectomy was done. And here 2 partial thickness scleral pockets, Hoffman's pockets were made, and which was made at 3 and 9 o'clock positions, and long straight needle was used, which was passed which is passed underneath one flap 1 millimeter from the limbus, while a 26 gauge needle is passed underneath the second flap, and the needle of the suture is exteriorized to the opposite flap. The middle of the suture, it is in the middle of the suture, it is pulled out from via the superior tunnel, and it is cut into 2, and it is threaded through the eyelet of this SFIOL, and the IOL is introduced via the main port, and it is placed beneath the iris, and the sutures are tied beneath the scleral flaps, and it is not exposed. Now coming to the CMT flex SFIOL, in few patients we use CMT flex SFIOL. Here the Technique is the same, but the T haptics are buried in the pockets, which eliminate the sutures. And for this, customized 23 gauge forceps is used for exteriorizing the haptics. This is a video showing the placement of the CMT flex via the main port. The CMT flex is loaded and it is injected using a cartridge, and the T haptics are exteriorized using special forceps. And it goes under the scleral flaps, thus eliminating the need of sutures. So coming to the results, here the mean age was 73, and although the range was between 60 to 89 years. The lens status other eye was pseudophakic, and the duration between the primary surgery was 11 years, and corrected distance visual acuity in the study eye was 0.91, whereas which corresponded to 6 by 36 of Snell lens. The cause for subluxation was studied. Intraopsonular dialysis was seen in 2 patients. Spontaneous subluxation was seen in 8, and trauma was a cause in 1 patient. And ocular predisposers which were found in our study were pseudoexfoliation and axial myopia. Other associations were primary open-angle glaucoma, and ERM was seen in 1 patient. The pre-op ocular investigations biometry average was 22.59, and specular microscopy it was 1785. OCT macula was within normal limits in 10 patients, whereas in 1 patient it showed an epiretinal membrane. Now, surgical intervention was done. In situ was done in 4 patients, and 7 patients SFIOL was placed. The okay.
So, which was the most, which had the best outcomes in these 3 groups?
So, in this future SFIOL patient had a better outcome, but we cannot say because there was a very marginal difference. When it comes to the safety of the procedure, none of the patient lost 2 or more than 2 lines of visual acuity, and efficacy was found to be like 6 by 9 was reached by 91% of the patients.
Why did you decide it was a subluxated bag complex, right?
Yes, sir.
So why wasn't the entire bag fixated in every case? What was the reasons to do an SFIL or explant and SFIL in some cases?
In case of closed loop haptic, when closed loop haptic was there, it was fixed. Or when there was a well fibrous capsule, then also it was fixed. In absence of such things, or more than the zonular dialysis was more than 180 degrees, in those patients it was not, SFIL was